So, if we had had a successful first stage, preferably normal first stage without induction, or after induction, this mother has had a successful dilatation of the os, and we are going to have second stage. So, all preparations should be made like any other mother, but we take caution that this mother is prone to a big baby, plus all the complications related to big babies. And preferably, this mother is at risk of a baby with birth asphyxia. And remember, because these mothers are prone to big babies, they are also prone to premature babies, irrespective of the birth weight. So either we are prepared to receive an asphyxiated baby or a premature baby. Therefore, we should be ready with resuscitation equipment to manage these two conditions. And we have said these babies may look big, but they may have all characteristics related to a prematurity, regardless of their size. So, second stage is carried out normally, like for any other mother, because we think that we have successfully maintained our glucose level in normal ranges, that is 60 to 120 grams per deciliter. And this mother is fully dilated, she's going to push, but we prepare to receive either an asphyxiated baby or a premature baby. So we should have all the requirements to save this baby. And after second stage, of course, third stage will be carried out like any other mother. There is nothing significant to this mother. So during postpartum, immediate postpartum period, insulin requirement often fall precipitately to levels below the pregnancy dose. So what do we do immediately? Postpartum, we have to check on the glucose levels, and naturally they may fall drastically down. This is very true in women who have undergone cesarean section because they are not allowed to eat in the first 2 days, but these days mothers are given anesthesia, which they can be able to eat immediately they are awake or move their legs, so at least the chances of going hypoglycemic may be low. So our worry is this patient going hypo and even going into ketoacidosis. So we monitor glucose cautiously, and we must give a subcutaneous dose that can, So this patient should be allowed to eat if possible, insulin monitored, and if it is very low, we can give a dose. No. If the blood sugar is very low, we are not supposed to give a dose of insulin. And then we can help this patient, increase the patient's dietary restrictions, fine-tuning and control of accomplished at home. So here we talk about if the insulin was gestational induced, usually it drastically falls. And if it drastically falls, we are going to adjust on the eating habits, the foods she eats and all that, such that we can uplift back the glycemic levels. If it rises drastically, we must give an insulin injection. And therefore, before we discharge, we must monitor the glucose levels. If this mother was on oral hyperglycemics, by the end of puerperium, this mother should be able to return on her oral drugs. For mothers who were diabetic pregnancy induced, most of them, their sugars will come back to normal and they may not need continuous treatment of DM. They will go back to normal. But for those mothers who are chronically with DM, they will be maintained back to their treatment. If they are insulin dependent, of course they will go with their insulin and continue with it. If they were non-insulin dependent, we can go back to our oral hyperglycemic. And during postnatal care, carbohydrate metabolism usually returns to normal soon after delivery of the placenta. Intravenous fluids are continued until the next meal. So this mother will generally go back. And then we shall talk of a few things before we discharge. Advise the mother to increase on protein and carbohydrate intake during lactation period for formation of breast milk. Remember, during pregnancy, we told them to control their carbohydrate intake. This time, before we discharge them, we shall advise them to increase on their carbohydrate intake in order to be able to sustain formation of breast milk. These mothers are very prone to non-wound healing or to wounds. So if this mother has had a cesarean section, this mother may have a problem with wound healing. So we talk, if it was a vaginal delivery and we carried out an episiotomy, this mother might also have a problem with wound healing. So we emphasize on hygiene. Because the body is having a very low resistance. So this mother should be given antibiotics to prevent or to treat infections which can be seen. We continue advising on blood sugar to be checked once or daily. And if this mother is insulin dependent, this mother's insulin should be administered due according to her levels. Remember, in the beginning, we had taught them that if your sugars are this range, you give this range, you give this. So they should be very participative in the management of their own health. So that one is also emphasized. Now let us briefly look at the drugs we have been talking about. Then we have the short-acting insulin or soluble insulin, which is given in hyperglycemic emergencies. This is an injection. Usually when this patient goes into hyperglycemic, we give them this insulin injection. The doses are adjusted according to the levels of glucose seen. Then we have oral hyperglycemic drugs. The first drug is glibenclamide, that is 5 milligrams OD, till when needed to stop, or it can be for the non-insulin dependent, they can be taking it through life. Then we have tolbutamide, its dose is 250, and metformin, its dose is 500 milligrams TDS. So these drugs for non-insulin dependent patients, they can be taken for life. But for insulin dependent, usually these patients are given insulin injection. Then immediate care of the newborn, the pediatrician should be present at the delivery of all babies of diabetic mothers. Resuscitation may be required if the baby is asphyxiated. This baby must be properly examined to rule out birth injuries, which are very common due to the big size. These babies are prone to clavicle fracture injuries, torticollises, Erb's palsy, facial palsies. So examination must be done carefully to rule out all this. But again, also DM, drugs, like we said, preconception, DM, oral drugs are is a very high risk of congenital abnormalities. So we cannot fully rule out congenital abnormalities. We have to be in position to examine and rule out whether this baby is having any congenital abnormality. Asphyxia, as I've said, is also very common. So these babies are prone to respiratory distress syndrome due to immature lungs. So these babies should be ready, or the midwife, you should be ready to administer oxygen if it is necessary. We also have to prevent hypoglycemia in these newborn babies. So what does it mean? We have also to monitor their glucose levels. And they are saying we treat low values of glucose, which are less than 2 grams per millimole, with 25% glucose infusion. At this level, we must learn how to reconstitute 25% glucose. Of course, we know how to reconstitute the 10%. There is available 5% on market, available 50% on market. So we should be in position to prepare 25% glucose, ready to be given to these babies who may prevent with hypoglycemia. And lastly, let us look at complications. Chronic complications are characterized by damage, dysfunction, and eventual failure of various organs, especially the eyes, kidneys, nerves, heart, and the brain. That is especially to the mother. So our management, we should be looking at such complications and trying as much as possible to prevent such complications. So we should advise this mother on family planning, and this mother should be advised as to why she should deliver few children. Low progesterone doses are advised, especially Norplant. Never give Depo-Provera, as it contains very high doses of progesterone. So let us advise them on methods of family planning before they could go home. And other general managements, hygiene, dieting, care of the baby, etc., etc. But let us be very cautious and keen on the nature of family planning they are supposed to take on. With these few marks, I think it is a good day. Thank you.